We're talking esophageal cancer. I'm Nasser Al-Turki from New York Hospital and Cornell. The hour is late, and most of you know most of what I'm going to say, so I'm going to go through it, and then we'll give some time for questions at the end. Esophageal cancer shows a worldwide map of the distribution of this fairly uncommon disease in the United States and in Northern Europe. The blue here is both Northern Europe and the U.S. The incidence of about 5 to 10 cases per 100,000 of the population, so it's not very common. There's an esophageal cancer belt that runs through Turkey, northern Iran, the Soviet Union, India, and China, where the incidence approaches 300 per 100,000 of the population, and indeed in China it's probably the most common cancer that they have. What's of interest to us is that almost 10,000 cases are reported in this country every year. The important event in the last decade is a dramatic increase in the incidence of adenocarcinoma of the esophagus. And squamous cell cancer is no longer the most common tumor of the esophagus in this country. There are probably about 60-40 squamous to adeno, or 50-50. In our hospital, about 50% or even more than that are adenocarcinomas of the esophagus. This report came from the NIH epidemiology branch and points to the point that I was just making. It is now one of the fastest growing cancer in the country, and has increased at a percentage of about 10% per year over the last 10 years. It is nonetheless began out being very rare, and it's still not a very common disease. What we've noticed at the same time is that the squamous cell carcinoma of the esophagus, the incidence has remained fairly stable, and the adenocarcinomas of the cardia have increased, but those of the stomach have really decreased. True incidence probably reflects the increase in incidence of Barrett's esophagus. Now, this paper was in the early 80s by Earl and Cunimelo, and sort of summarized the situation at the time, the preceding decade from the 70s to the 80s, about the situation for surgery for esophageal cancer. They reviewed about 80,000 patients. About 60% were operable, 40% were actually resected, miserable hospital mortality, and a miserable 5-year survival. Now, 10 years later, this fellow there, Muller, published an update in the British Journal of Surgery. Again, an enormous number of patients collected from various centers, managed to cut the mortality in half, but the survival was still horrible. Nothing much has changed since then, except our ability to perhaps to do a little safer operation. Now, the survival is so bad that the only chance really of getting a good result is focusing on those patients who are at high risk and being able to follow them and cut the cancer in early stage. Achalasia is a known precancerous disease of the esophagus. The incidence there is probably around 5%. Nobody knows exactly. Figures have varied between 2 and 7%. 5% is a good estimate. They're all squamous. They're all in the middle third, all incurable. The reason for that, of course, is that the esophagus is so damn big by the time the tumor happens, the patient doesn't notice the difference in his dysphagia that's been there for 20 years until it's really very advanced. Diverticula, Zenker's diverticulum, the incidence of squamous cell cancer is probably less than half of 1% there, and there are about 28 cases of cancer reported in diverticula of the thoracic esophagus. So a diverticulum is a very exceedingly rare site of carcinoma, but it could happen. The Plummer-Vincent syndrome you all know about, the upper esophageal west, the iron deficiency anemia, and the chorionekia, which is the spoon-shaped nails, and those patients often increase risk for hypopharyngeal carcinoma. Corrosive injury of the esophagus, again another premalignant lesion. Those patients, if they do not undergo esophagectomy for one reason or another, they should be followed up very carefully, usually by cytological exam. And those patients will develop squamous cell cancer at a much higher rate than achalasia. The exact percentage is not quite known yet. Most of them, as I said, all of them almost entirely are squamous, are in the middle esophagus. They are said to have a little better survival than the others, than say other squamous cell carcinomas, primarily because people think that the intense fibroblastic action in the mediastinum from the initial corrosive injury perhaps limits the extent of nodal spread. I don't know if that's true or not, celiac disease is another, ankylosis is an autosomal dominant disease in which about almost certainly 100% of the offspring will develop squamous cell cancer by the age of 60. And of course, the one that we're interested in is Barrett's esophagus, as you know what that is. And this is the one that has been on the rise in North America and in most of Western Europe. And this is a case of Barrett's esophagus. You can see the salmon pink colored columnar epithelium right here. This is squamous, and that area here is a very early carcinoma of the esophagus. This is a good pickup. This is a patient that should have 100% survival at 5 years. Now, the issue is how to follow those patients, whether it's achalasia or Barrett's or otherwise. And clearly, the most frequently employed method of follow-up is endoscopy. This lesion here, very small ulcer, is a squamous cell, a T2 squamous cell carcinoma of the esophagus. So do not be fooled if you're scoping somebody and you see something that looks pretty cheap like this. Make sure you biopsy because you can get a cancer in there. We've come up with using the brush cytology in order to cut down on the expense of the follow-up, the endoscopy. It's not been very popular. We still think it works. It's an NG tube. You cut the tip off, put a brush in it, pass it like you would a normal NG tube, and then advance the brush, brush it, put it back in, pull the tube back, brush it again. You can get like a cytology prep of it. It really works well, but it has not been very popular in this country. Now, does it work? This is clear. This is the result of a large series from Europe in which patients were subjected to radical resection, so we're quite sure about the extent of the disease in them, and you can see that you can get upwards of 90% survival for patients in stage 1. So it does pay to pick up those cases early, and you can certainly cure those patients, but obviously the survival then drops off with advancement in stage. Well, what influences the stage? About 5-6 years back, we collected 110 patients and analyzed them for various factors, looking at which one would become an important determinant for survival: cell type, squamous versus adeno, location, upper, middle, and lower, histological grade, side penetration, and nodal status. It didn't make a difference whether a tumor was well differentiated, moderately differentiated, or poorly differentiated. It seemed like if you just included the patients who had negative nodes, the grade of differentiation made no difference in the survival. And it did not make a difference whether the tumor was small or large. The most important determinant here, although it was apparent that smaller tumors were generally better than larger tumors, in reality, once the nodes were corrected for, they had the same survival. And that's an important point, because occasionally you will see patients with fairly large tumors, and these patients should not be considered inoperable primarily on the length of their tumor. What was important, though, is the degree of penetration through the esophageal wall. This one is penetration to the submucosa, and this transmural disease, and you can see as the disease progresses through the esophageal wall, the survival drops off. This was statistically significant, and of course the presence or absence of nodes. Negative nodes did better than patients with positive nodes. This is not the usual staging. There is no N1 and N2 with current staging. This is a different staging system. This is the current staging system, and you all should be familiar with it. T1 is tumor that is in the submucosa. T2, tumor in the muscularis propria but not through it. T3, tumor through the muscularis propria into the adventitia. And T4 is tumor that invades the spinal structures. Again, N0, no regional nodes. N1, regional nodes are involved. And there's some debate now of whether you should break up the regional nodes to various stations and come up with N1s and N2s, much like people do for gastric cancer. That debate is not resolved. And at this time, patients either have nodes or don't have nodes. And of course, M0 and M1. Stage groupings are right here. We have a stage 1 in which the tumor is in the submucosa with negative nodes. If you have negative nodes but the tumor has grown transmurally or is in the muscle, it's 2A. And 2B and 3 are patients who have positive nodes regardless of wall penetration, including T4 disease. We're into the mediastinum. And now stage 4, only patients who have metastatic disease, visceral or distant metastasis. And as you can see from this large series collected worldwide, this is a good stage system because it predicts survival fairly well. You can say, generally speaking now, that patients with stage 1 should have about a 70% survival rate, patient with stage 2 about 40%, stage 3 is about 15%, and patient with stage 4, I don't see that over here, but should be pretty much close to 0. Now, the issue then, if you think that it's important that the wall penetration, the nodes are important, how do you go about figuring that pre-op? And it's very difficult for the esophagus. People use the CAT scan, and we used to say if you look at the CAT scan like this, and you got a thickened esophagus with a blurring of the esophageal margin, it's probably transmural, that is, it's probably T3. Well, you're right most of the time, but you're wrong sometimes. In this situation here, you can see a fairly non-thick esophagus, but there is loss of that fat plane between the esophagus and the aorta for about 90 degrees, and that tumor, although it did not blur the margins, was certainly transmural. Indeed, it was intra-aortic. So that was a T4 lesion. It's not a good study, but it was the best we had. And what we think is a better study is the endoscopic ultrasound, which is acquiring more and more of a role in the staging of esophageal cancer, and I think is soon going to be the gold standard as people become more comfortable with it. This is the probe within the esophagus, the balloon distended, and you can see there are 5 normal layers of normal esophagus. And on this study there, you see that the normal layers that are noted here are now distended by this hypoechoic lesion, which is still contained within this thick white line, which is the adventitia and the muscle layer. This is a T2 tumor. Now, if you look here, these are the normal 5 layers. You come around the hypoechoic lesion here, and you no longer see that thick, nice white line. It means that it broke through the adventitia. This is a T3 lesion. And here, if you look, this is the aorta. Somewhere here, the esophagus with the probe in it, and between them, there is just an entire hypoechoic density, this tumor that grew into the aortic wall. This is a T4 lesion. Now, the problem with determining whether the nodes are positive, as you remember from your lung cancer series, is people have correlated the size of the nodes with the incidence of metastatic disease in the nodes. Not so in the esophagus. You can have a 1 millimeter node that's positive and a 2 centimeter node that's negative. So size is not really a good correlation for esophageal cancer. What is a good correlation is whether the nodes on endoscopic ultrasound are hypoechoic like tumor was, and whether or not they're sharp, have a nice little round appearance. This here is a normal node. It has a nice little round, it's small, it has a rounded appearance, and there is some internal structure to the node that suggests that it is a negative node. This is an N0. This is a huge node, and you can see it's almost the same texture of that tumor over there. This is a T3 N1 lesion. This just shows another, the value of endoscopic ultrasonography is limited to the determination of wall penetration and nodal involvement. Occasionally, you will put the probe down like this and look at the left lobe of the liver, see a little met in there. That's not the primary purpose of doing the endoscopic ultrasound. When MRI came about, people were interested in it. Maybe it's better than the CAT scan, not so. It overestimates the tumor invasion about a third, and it's only a 50% accurate in determining lymph nodal metastasis, just like the CAT scan was. We don't use MRIs anymore, we always use CAT scans primarily to assess the presence or absence of distant disease. Our state would include an EUS for wall penetration and nodal disease, and a CAT scan to look at the presence of distant metastasis. This shows you here how much the EUS is better than the CAT scan in determining wall penetration. When the tumor is fairly small, limited to the submucosa, is not invaded through the muscularis propria, it's a little better, but almost twice better as the CAT scan, but not great. T3 is where most of the tumors are. The tumor has gone entirely into the adventitia. That's an excellent test, and it will make you avoid operating on patients whose tumors have grown right into the mediastinum, into the aorta or the tracheobronchial, etc. Definitely better here in determining the presence of nodal positivity, not great for M disease. So we still combine the two together. We think complementary. We've had about close to 200 patients with carcinoma of the esophagus up till now. Note several things. The marked male predominance. The male to female ratio in squamous cell cancer is probably about 2 or 3 to 1. For adenocarcinoma, it's more like 9 to 1. Adenocarcinoma being primarily, in my opinion, a disease of the Caucasian male. Note again the white predominance, and that reflects the increased incidence of adenocarcinoma. There's a litany of symptoms that you're all familiar with, dysphagia being the most prominent, and you're all familiar with the adage that a patient with dysphagia over 40 years of age should be considered carcinoma until proven otherwise. Other symptoms are really not quite as frequent as dysphagia. The average duration of symptoms is 3 months since they seek medical treatment. I think that everybody should do their own endoscopy. Sometimes that's not so, but I think it is quite important that the surgeon who's going to operate be able to do the endoscopy himself. One thing you'd want to know for sure if you have a barren cancer such as this one over here is where your squamocolumnar junction is. If you go in there and do an esophagectomy, especially if it's an early carcinoma, it'd be quite silly to leave columnar mucosa behind. You need to know exactly where it is because that is pre-malignant, and you don't want to have a cure compromised by that. You also want to look for submucosal nodules or satellite nodules in squamous cell carcinoma. This patient's tumor is down there somewhere, and this is a satellite nodule extending along submucosal lymphatics proximally in the esophagus, and is the main reason why I think all patients with squamous cell cancer should have a subtotal esophagectomy with an anastomosis as high up as possible, which is usually in the neck for me, because there is incidence of multicentricity in squamous cell carcinoma of about 15%, and there is a propensity for submucosal spread along lymphatics in the submucosa, so you can have a tumor down there and spread along the lymphatics with another spot right here. So I think you ought to always do subtotal esophagectomy. Now, among the patients that we've seen, we've had squamous in 30%, adeno in 70%. That goes back to the point we made earlier. About half of them had associated esophagus, which makes us believe that that is probably the reason we're seeing the increase in incidence of adenocarcinoma. The great majority were in the lower third, reflecting the common location for adenocarcinoma. If you were to look only into squamous cancer, probably middle third would have a slight advantage over the lower third in terms of frequency. The upper third generally is a rare site. Probably about 10% across the board occur in the upper third, and carcinoma in the cervical esophagus probably occurs in another 10% of patients. So the great majority of tumors are in the middle and lower thirds. Again, this is the staging of the patients that we've seen, and shows you between stage 2B, which has positive nodes, stage 3, which has positive nodes, and stage 4. We put it all together. I can't see it from here, but that's 70% of the patients had advanced disease. So it's pretty bad disease primarily because the symptoms will not occur until they're fairly obstructed. Now, once you've made the diagnosis and you've staged the patient, I'd like to make one before we go on to this is another part of the workup that we insist upon doing for patients with carcinoma of middle and upper third is a bronchoscopy, and I think that's important and should be done by the surgeon, not by a pulmonologist, to look and evaluate the possibility of invasion of the airway. So that's an essential part of your staging system. Now, once you've made the diagnosis and you've staged the patient, what are your options? There's a lot of confusion about that. People talk about different forms of therapy. Your options are esophagectomy, doing chemotherapy followed by a planned operation, radiation followed by a planned operation, chemoradiation followed by a planned operation, chemoradiotherapy alone, either concurrent or sequential, and radiotherapy alone. There's no other disease that has so many options that nobody really knows what the right thing is. The state of the matter right now is that surgical resection is the standard of treatment option. Everything else here, from 2 on down, from 2 to 5 actually is investigational, and radiotherapy, in my opinion, is worthless. Just a word about radiotherapy here. Not about 3-4 years ago, there's a study that came out in the New England Journal of Medicine that is hailed by the oncologists across the country that compared radiation versus radiation and chemotherapy. And regardless of what happened in the chemoradiation arm, the radiation arm had a 60% local recurrence rate. So in my opinion, that study sealed the fate of radiotherapy as the only modality of treatment. So I don't think there's a place for it except rarely. At least as far as I'm concerned, our investigation, when we get to them in a second. Now, once you've decided that you're going to treat the patient, your standard treatment, unless you have a protocol of some sort, is to operate on the patient. What are your options? You can do a surgical resection, obviously, or a bypass, which I think that one cannot do except extenuating circumstances, like a tracheoesophageal fistula in otherwise very, very healthy, non-infect patient, which is rare. And of course, one, in my opinion, stay away from esophagostomy and gastrostomy, which are procedures that prolong the misery of a dying patient and need not be done. If you're going to resect, you can do it through a transthoracic approach, transhiatal approach, or more recent, especially in Europe, a thoracoscopic esophagectomy, which I think is a waste of time. Now, this shows you the most common operation for esophageal cancer done in the country, which is the Ivor-Lewis approach, done through a right thoracotomy. The original Ivor-Lewis operation was right thoracotomy and thoracotomy only. And you see here the thoracic duct and the azygous vein. The esophagus is just fished out from the mediastinum with the tape, and you all know how to do this operation. Here's the tumor, and you just go along the esophagus, pick up a few nodes here and there if necessary, and open the abdomen, free up the stomach. You usually do that first. Bring up the stomach into the chest and do your anastomosis above the level of the arch of the azygous vein. That's important if you're going to avoid the problems with reflux. Now, McEwen added a modification to that and said, well, you know, you've done all of that, why the heck not put the anastomosis in the neck where it's safer? So he added the third incision, and so when you do the three hollows, it's not really a classic Ivor-Lewis. That's the operation that I think if you're going to do this, you better do an incision in the neck and take the stomach up to the neck. Now, this is the most common operation done in North America. It is important to know that you can do operations through the left chest for carcinoma of the esophagus if the tumor is located at the GE junction or the lower third in the left chest. It gives you an ideal exposure of the upper abdomen once you get used to it, particularly in obese patients who you don't want to struggle with that left upper quadrant. So you can do esophagectomy from a left thoracotomy. And we'll show you that in a second. Of course, this is the second most common operation that is particularly loved by the general surgeons. A neck incision popularized by Dr. Oringer, and you do your usual stuff, then cut the stomach up here, create a tube, pass it up into the neck. You're all familiar with this one. These are Dr. Orange's results, and you see his overall survival. I think there were about 300 or 400 operations done for malignant disease. This was presented at the ATS in 1993, and 27% survival at 5 years. And if you look here, a variety of complications. This is almost a routine part of the operation. I wouldn't necessarily consider that a complication. About a 4% incidence of splenic injury, 10% recurrent nerve palsy, and anastomotic leak is about 10%, and that's an important point because I think, and people are beginning to realize now, that anastomosis in the neck leak more frequently than anastomosis in the mediastinum, and that paradox is generally made lighter by the fact that if they leak in the neck, it's okay. 50% of them have strictures. These are really the results of the person that is most experienced in doing this kind of operation. These are generally within the acceptable realm for morbidity of esophagectomy. The mortality was 5%, which is pretty good. Now, the survival that I showed you earlier, 27%, is clearly stage dependent. We don't like this operation very much. We think that it compromises the survival, and that's an ongoing debate, but it's certainly an acceptable operation. And for your purposes, it's one of the most commonly performed operations, certainly a standard operation in most of Europe and in North America. Now, people have compared transhiatal versus thoracic esophagectomy, and the fact that there is no significant difference in morbidity or mortality between transhiatal and transthoracic esophagectomy. There was an argument at some point in the past that, well, maybe the patient would compromise pulmonary function with the transhiatal a little better. Not true. You embarrass memory functions to the same extent. The overall survival rate is identical regardless of how you remove the esophagus. I will show you the slide only to point out to you the value of experience and doing the thing that you know how to do. This series came, I think, from Ontario. I don't remember exactly from where. And they did compared transhiatal and transthoracic 26 and 26 patients. The leak rate about 20% in the neck, which I told you is generally higher than it was in the chest, which is we're all finding out. No significant difference in other morbidity, no significant survival difference, and those individuals recommended selective operation, selective transhiatal. Now, this came from the Ellis group at the Leahy Clinic, and this is certainly a very good group, a respectable group, and they compared the transhiatal with the transthoracic. You can see 65 versus 30 patients, and showed that there's really no difference in respiratory complications, a little higher leak rate in the neck than in the mediastinum, and well, the punchline is this: double the mortality for transhiatal versus transthoracic, and double the mortality, the morbidity somewhere. And the point of the matter is that if you do an operation that you are not used to doing, you are going to have a learning curve, and that's why these operations are identical. The question is, which operations would you do? If you're used to doing the transhiatal, it would be silly to do a transthoracic or vice versa. You do what you know you can do safely with a low mortality and low morbidity. Now, back in 1981, Dr. Akiyama presented a series of patients from Japan at the American Surgical Society and said that the survival overall was 34%, negative nodes was 50%, and positive nodes was 15%, and everybody said, well, disease in Japan is just a different disease. It's not the same. It's just not the same. And of course, we refuse to accept what the Japanese do, which is they do a good job. They go in there and they do a rectal operation, take all the nodes out. He planned out the nodes, know exactly in about 200 patients where the frequency of metastases were along the lesser curve and so on. A guy from Scotland, I think he was from Scotland, Dr. Logan, had proposed a similar operation about 20 years ago, and he called it the en bloc resection, and he said, well, you know, you're going to go in there and there's a big old tumor in the esophagus, but the way you remove the esophagus, you just pick the organ up and just sort of core it out like you would a leiomyoma. That cannot be a good operation when you treat colon cancer in a different way and gastric cancer in a different way. So he proposed that you take the esophagus within an envelope of tissue that includes the pericardium, both pleural surfaces where they abut on the esophagus, and the thoracic duct posteriorly. That was called the en bloc resection. Their survival then was 16%, very non-selected group of patients, which was pretty good for the time, but the mortality was too high. And people did not like it very much because it took forever. We still like this operation. We think that's how it should be done. We're obviously in the minority here. The operation entails not only removing the esophagus, but removing a wide area of tissue around the esophagus, so you decrease the local recurrence, do a radical lymphadenectomy in the chest, up from the carina to the hiatus, go back in the abdomen, and do a radical operation, clearing all the lymph nodes superior of pancreas into the hiatus. This operation, as you can see here, this is the esophagus now. You can really not see the esophagus very well. This is the spine, this is the aorta, and the thoracic duct and the tumor with the pleural attachments and the pericardial attachments are all included in there. The recurrence rate here is very low locally. The local recurrence rate is probably less than 5%, which sure beats 60% of radiation therapy. The operation can be, this is shown right chest here. We use the right chest if the tumor is close to the arch or close to the carina. We think that allows you better visualization, better dissection. If you do it from the left chest, which sometimes we do for tumors located at the GE junction or the lower third, you can enter the abdomen by making a semilunar incision in the diaphragm way at the periphery. You don't want to make your incision in the diaphragm this way because you denervate a lot of the diaphragmatic muscle. If you do it peripherally, you only denervate this part here and then reattach, and that allows you excellent exposure. You can do it from either a left thoracotomy or a right thoracotomy. The operation was reported in 1983, I believe, with an 11% mortality, and again, a substantial morbidity that, did not catch on and still has not caught on. Dr. Demeester presented his data in 88 with a 7% mortality and an overall 60% survival for a highly selected group of patients. Now, we've done a bunch of those. I think we've done about 80 or 90 cases. This was a while back. We have had about, at the time of 80 cases, 63 were done through a thoracotomy, 14 through a right thoracotomy, and 3 were transhiatals. Not all of these were on blocks. 30 were on blocks and 50 were standards. Once the esophagus was removed, clearly our option of choice to reconstruct the esophagus is the stomach and usually create a gastric tube. We all know how to do that. We can talk about it in the question time if you'd like. We used the colon about 10 times. The mediastinum, the anastomose was located in the mediastinum, and 26 times, 52 times in the neck. This is the kind of specimen that you'd get. Esophagus right here, the tumor in it, and this is all the periesophageal tissue, and this is the thoracic duct and the azygos vein right there. You get the hospital mortality down to about 6, 5, or 6%, and it did not really matter whether you did this on block resection or the simple, more standard resection like I showed you earlier. You can have comparable mortality. There's the argument that one is higher in mortality is no longer valid, but we can go back to the learning curve. One should not underestimate the morbidity of esophagectomy no matter how you do it. It's a fairly substantial operation. Patients rehabilitated for 2 or 3 months after the surgery. Our mortality was about 5% or 6%, but there was a substantial morbidity here. Chylothorax, anastomotic clique, necrosis of the tip of the gastric stomach, empyema, etc., etc. The overall survival for all groups was 40% at 5 years. Didn't really make much of a difference whether or not it was squamous or adeno. What did make a difference, though, whether the nodes were positive or negative, with negative nodes having a survival of about 60% and positive nodes down there with about a 20% survival. Now, I will have to mention you quickly what's going on. The new thing is the 3-field lymph node dissection. If you think of the fields, the nodes are involved 3: the abdominal field, the thoracic field, and there's a third field, which is the cervical field, which includes the nodes in the lower aspect of the neck and along the recurrent nerve. And that is the new hot topic. I don't know, may or may not be asked about it, but it's important to keep it in mind. The Japanese have again introduced this back in the, actually started doing it in the mid-80s and reported it only a few years back. And what we found through their data was if you had tumor in the lower esophagus, your chances of having positive node in the neck, unbeknownst to you before, was 1 in 4. So there is a substantial, the message here, there is a substantial chance of having positive nodes in the neck along the recurrent nerve or in the deep cervical nodes in patients with lower third, middle third tumors. Of course, the mediastinal nodes were most commonly involved. The other message is that that chance of having positive nodes in the neck increased. This is the relation between nodal metastasis and the cervical metastasis and T-stage, increased as you increase depth of penetration. The patients who had T1 lesions had 60% and 80% if you had T3 or T4. That will change things in the future, not right now. Suffice it to say that there is a substantial chance of positive nodes in patients with tumors of the intrathoracic esophagus. Now, what the Japanese are trying to say is that if they remove these nodes, survival is better, and they show these two graphs which are statistically significant at 27% survival versus 43% survival in patients who had that third field dissected versus not dissected. That remains to be seen. That's highly arguable. What they showed, which was interesting, was if you took patients only with negative nodes, the patients with negative nodes who had all 3 fields dissected had a better survival than the patients with negative nodes who had only 2 fields dissected. That immediately should imply to anybody that those patients he had occult nodal disease that was not resected. So this reflects just better staging. Now, if you look at the patterns of failure following surgery for esophageal cancer, and these are taken from autopsy data done about 4 to 6 months after the diagnosis, you see that patients had, these are 3 series here, for the most part, let's say 9 to 10% of patients had local recurrence, 2 to 10% had distant recurrence, but both local and distant recurrence were present in the majority of patients. So it is clear that patients will die of metastatic disease or recurrent local disease. And hence the rationale for adjuvant therapy. You should try to enhance local control, a mechanism that will prevent you from having the 30 to 40% lower recurrence rate. That really defeats the purpose of your operation. And of course, to eradicate micrometastasis so that patients would presumably not die of metastatic disease. So you would go ahead and give the chemotherapy pre-op. Before I get into chemotherapy pre-op, I will say one word about post-op chemotherapy. It does not work. There's not a shred of evidence anywhere that post-op chemotherapy makes an iota of difference. Now let's talk about pre-op chemotherapy. The idea, if you give it pre-op, is of course the circulation of the tumor is undisturbed, so you got proper delivery, improved delivery. The patient is healthier before you descended on him, so he can tolerate it better. You can see who's going to respond. So if they respond, you can give them more chemotherapy. If they don't respond, be silly to give them post-op chemotherapy. Hopefully you will improve your resectability, and then eventually all this would result in improved local control. Well, what's the downside? The downside is, of course, you may delay control of the tumor, and you're giving the patient chemotherapy. You don't know if it's chemo-resistant or chemosensitive, and I have seen patients who have obviously progressed, as I'm sure you all have, on chemotherapy. You allow for the emergence of resistant clones. Seen patients who had been treated by chemotherapy, got a good response, got their esophagectomy, 6 months later had the fulminant recurrence I've ever seen. So you may allow for the emergence of the resistant clones, and of course the patient may feel so good he might refuse the operation, which is not a good idea. Now, everybody comes across a paper, so gave some chemotherapy followed by an operation, had great results. You'd wonder, there are about 100 papers out there about why chemotherapy is the hottest thing in town. But why aren't seeing the patients live longer? Because there are only 2 randomized trials that I know of which are a final arbitrator in that issue, whether chemotherapy works or not. A trial by Dr. Roth and a trial by Schlag. And this is just, I think it's Vindizin and platinum and bleo versus nothing at all. Patients got the chemo post-op here and nothing here. No problems from the chemo. Nobody died from that. The operative mortality in the combination treatment group was 12%, 0 in the surgical group. Resectability was great. Survival was identical. No difference. Then they went into this small group of patients and they said, but in a subgroup analysis, the responders versus the non-responders, those that responded to the chemo did better. And you know immediately, although they may have some merit in that argument, numbers are just too darn small to support that statement. So the message from this does not make a difference. The message from this, same thing. Platinum 5-FU control, and there was some problem with chemo here. The mortality here leaves a lot to be desired, the operative mortality. But then again, survival figures are the same. So as far as I'm concerned, there is no evidence whatsoever that preoperative chemotherapy works and is advantageous over surgery alone. What about preoperative radiotherapy? This has been done repeatedly over the last 10, 15 years. And if you just look at the various treatment regimens, various doses, and sandwich before, after, and all what you will, 11% is really not a whole lot of difference between those that got the radiation pre-op and those that went to surgery right off the bat. There is no evidence there. Now, there is combination of chemo and radiation. I am not aware of a randomized trial that really looked into that issue specifically, although I have not searched literature carefully for it. But most surgeons would shy away from the combination chemo-RT followed by esophagectomy when it was done by the Wayne State group way back in the early 80s. The mortality was really very high. What you see is something like that. You give the guy chemotherapy, the tumor literally melts away. And you get this nice little ulcer that's now reepithelialized, and you say, the gastroenterologist says, no evidence of cancer. But this guy had positive nodes along his recurrent nerve. So I don't know that the data mean a whole lot unless you just are subjected to resection and then analyzed. Just to make the point, if you look, these are data from the phase 2 trials of the University of Michigan when they gave pre-op chemo and RT. I'm sorry, this was a study from the University of Michigan. They gave pre-op chemo and radiation followed by transhiatal esophagectomy. This was followed by a randomized trial, which was published in abstract form but not in a paper form. It was a randomized trial of pre-op chemo RT followed by surgery versus surgery alone. And the abstract said there was no difference in survival as well. So that's the answer to the early question. This is their initial phase 2 results. Obviously, the T0N0s, which received the chemo and radiation and then esophagectomy, did very good. No surprise there. Those that were stage 2A and B and stage 3 had a little better survival, better than their historical controls before they did the randomized trial. When I plotted our survival for the en bloc, you can see it's right there. And it's about the same. So one should not be carried away with the phase 2 trial for combination therapy. Why don't we do 10 minutes about palliative therapy, and then we can stop for questions. Very quickly, the palliative measures: do not underestimate the role of surgery for palliation, but you only can do it if you can do it safely. Because there are other methods of palliation. Chemotherapy can melt away tumors. Indeed, chemoradiation, I think, should be the standard of palliation if you want to use it. There's bouginage, endoprosthesis, laser, electrocoagulation, etc. The one that is most commonly preferred by the gastroenterologist, the endoscopic laser therapy. What are the advantages of laser therapy? It is done as an outpatient. It's expeditious palliation, no maximum dose. You can do it as many times as you want. The disadvantage, of course, is that you fail to eradicate the tumor. It's mainly establishing luminal continuity. The preferred way of doing it is endoscopically with a flexible endoscope. You put it and you do what we call the retrograde treatment, meaning you go in there, you pull the scope back until you see the tumor come in front of you, and you buzz it and do this in a retrograde fashion. You get a little burn like this immediately, and then it blanches, and then it sloughs away, and you get luminal continuity after that. Sometimes you can have a tumor such as this, and you do antegrade treatment. It's a little dangerous to do the antegrade treatment unless you really experienced it, because you might just punch a hole right into the mediastinum. This is upside down, but you can imagine what it is. You got the same problem, a stricture. You want to laser it. You dilate with a balloon, and then allow the endoscope to go through and laser it. It effectively palliates about 80 to 90% of the patients. You can do it as many times. Usually, most patients are palliated within 2 to 3 sessions. The duration of the benefit is about 3 to 6 months. You should expect pain, fever, and leukocytosis. We used to keep them in the hospital because we were concerned about the perforation. No longer. They can stay only for a few hours. There's about a 10 to 30% incidence of porphyria, and there is a significant mortality. We don't really like it very much. We use it for metastatic disease, either metacontraindication, or obviously if there is recurrent disease after an esophagectomy. There are some things that are classic for laser, but some things that are not going to work if you do the laser. For example, this patient here has submucosal tumor that infiltrates the wall. That's not going to work. You got to have something to buzz. If this patient has a carcinoma of the cervical esophagus, you got to have the patient stay put for you to buzz the tumor. The cervical esophagus, that's not going to happen. It's going to move all over the place. If it's angulated like that, it's not going to be easy to do. And if it involves more than 9 or 10 centimeters of the wall of the esophagus, even if you buzz the whole thing from top to bottom, you'd be left with an aperistaltic esophagus. It's not going to palliate anything. Now, the other one is bougonnage. You can do it with the scope down, put the savory guide wire, the savory dilator, stretch the tumor up, and you get a result for a few days, maybe a week if you're lucky, but tumor snaps shut right again. And that's why it's really a short-term benefit. It's fairly safe if you can do it, but it's short-term benefit. We use it if we have a stricture and we don't have the diagnosis, so we'd stretch the tumor with a savory dilator, get the endoscope and make a diagnosis, but that's not going to be lasting palliation. If you want some lasting palliation, you might want to put an Atkinson tube like this one here. It requires some experience to put that thing in there. You mount it on a savory dilator. You measure the tumor, you see how far it is from the incisor, top to bottom, and this and that, and then you get it in the right spot. Right, this one here, this is squamous cell cancer. This is the prosthesis in place. But then you get some ugly pressure necrosis from the prosthesis here, and some of those have sort of eroded into the big A, and they've or it can get some tumor overgrowth and you obstruct prosthesis like that, or you get some reflux and bleeding and that sort of stuff. It fails out. It's inexperienced hands. It works fairly well. And I think there are a couple of places around the country that do it. There are complications, of course, failure. You can't do it. You can perforate the esophagus. If you do perforate the esophagus and you recognize it, you just leave the tube in there. It will seal the perforation. That's the answer to that problem. You can get obstruction, like we see, tumor overgrowth, but more commonly you can get obstruction from food material and instruct the patient that he can only liquid soft foods and stuff like that. It can migrate into the stomach 7% of the time, and of course you can get fatal hemorrhage about 1% of the time. This guy is over in Holland, and he's one of the leaders in this field. So these are the best results. And of course you can coagulate the tumor with bipolar electrotherapy. And last but not least is photodynamic therapy, in which you give photosensitizing chemical to the patient and then subject them to 600 I don't know what it is. The wavelength is about 600, and it activates the photochemical reaction and releases single oxygen. This has been published in the papers a couple of days ago as an innovation in the treatment of esophageal cancer. It was around for about 10 years now that I know of. And you can see, even though it's a treatment directed at tumor endoluminally, you can get perforations and chylothorax from that sort of thing, and tracheoesophageal fistulas. So this is not benign therapy, and really its only role, I would think, if you have somebody with a very superficial cancer who is completely inoperable for a variety of reasons, you can subject the photodynamic therapy. I think that's all I have, and we have a few minutes for questions. Yes.
How aggressive do you get with laser ablation?
I'm sorry?
How aggressive do you get surgically with laser ablation?
Well, assume he did the laser because the patient was inoperable in the first place, and that does not change once he's perforated. So you treat them conservatively. I would treat them conservatively. I would put a chest tube if necessary, put them on antibiotics, MPO, that sort of thing. You may consider putting a stent in to seal the perforation, but I don't change my policy if I thought they were inoperable to begin with. Yes?
This is surveillance for patients with Barrett's esophagus. I got the impression you just brush biopsies, or you do the quadric biopsy.
We scope them depending on whether or not they have dysplasia or not every 6 months to a year, and we get biopsies, at least 2 biopsies every 1 or 2 centimeters. So if I have a patient who has 6 centimeters worth of Barrett's, he's going to have at least 12 biopsies.
Does the pre-fetal lymph node dissection for metastatic disease, does that hold up for all cell types or just squamous?
That's just squamous.
Makes sense to do all that lymph node dissection up in the back if you're just dealing with potential adenoma.
There are data that are not yet in publication that suggest that this is the case too in adeno.
any data on patients who have had, say, for instance, 2 courses of chemo, 5 years platinum, and then a course of radiation, and then say have a follow-up CT scan before surgery and show a response to the tumor, and then undergo resection, and then the specimens are quote sterile. In other words, no evidence of residual carcinoma in either the lymph nodes or the esophagus. What the real question is do they really have any significantly longer survival than, I mean, intuitively it's
You're talking about giving chemo and RT with curative intent, not with preoperative intent.
no preoperative and then operating on them.
Oh, I see. Okay. You sterilize about 10% of the patients have a pathological complete response after chemotherapy alone, after radiation alone. You probably double that if you give them combined chemo and RT. So somebody who gets chemo and RT followed by an operation, the odds of having cancer is about 80%. And 20% they will be a complete responder. Now, what happens to those? We've indicated that there is some data to suggest, small data, that the people who respond do better. But overall, the responders are very small, so they don't influence the overall picture. Does that answer your question? Maybe.
In Barrett's that you're following, what biopsy result did you expect?
High-grade dysplasia of cancer.
What's your technique for the, what's your anastomotic preference, suture materials?
I hand sewed, but you can do what you're comfortable with.
With Barrett's esophagus, is it preventable by doing a reflex procedure and then?
No. You do an anti-reflux operation for Barrett's esophagus for its own indications, but not to prevent cancer. There's no evidence that it prevents cancer.
Is endoscopic ultrasound generally considered to be better than CT for nodal evaluation?
Yes. The problem with that, of course, is that the experience is not widely disseminated, or people not gotten up to speed with it yet. It's the instrument costs $100,000 to obtain, and it requires at least 100 cases for you to get up to speed and learn how to interpret it.
I'm going to be talking about one of my least favorite subjects, endoscopy, and my most favorite subject, the esophagus. We'll try to work through the endoscopy stuff sort of quickly and save room for the second hour for the esophageal stuff. The outlines, I think, are rather complete. The slides follow the outlines very closely, so I don't think you'll have to take too many notes. We're not going to be able to get through all of the esophageal stuff, unfortunately. I think I've stopped at the end of the slides, at the end of perforation management. I'm not sure we're going to get through all of that either with the amount of stuff that we've been assigned to cover here. So let's get going. We'll first talk about bronchoscopy quickly. In terms of indications, indications include evaluation of clinical symptoms, investigation of specific pertinent findings on X-ray or other function studies, and therapeutic procedures. And we'll go over those all individually. Evaluation of clinical symptoms would include evaluation of persistent cough without an obvious etiology. On examination, if you find localized wheeze, it's oftentimes a sign of airway obstruction and should be investigated by bronchoscopy. Hemoptysis, if you can rule out a source from the GI tract or from the nasopharynx, should always be investigated bronchoscopically. Patients who have persistent purulent sputum occasionally are candidates for bronchoscopy, as well as patients with. This is more important to evaluate radiographically first, and follow that with bronchoscopic evaluation. In terms of specific radiographic findings, patients who have persistent pneumonia that fails to clear with standard antibiotic therapy, electrolysis that fails to resolve over a relatively short period of time, a period of several weeks, a mass on chest X-ray that's suggestive of a neoplasm. Most patients with diffuse lung disease should undergo a diagnostic bronchoscopy with transbronchial biopsy. as the first step in evaluation as opposed to open lung biopsy. Occasionally, patients who have an undiagnosed pleural effusion or bronchiectasis are also candidates for bronchoscopic evaluation. This is the typical type of infiltrate / atelectasis or segmental collapse that would be appropriate to begin evaluation of bronchoscopy as the first step. And then evaluation of function abnormalities, particularly specific abnormalities seen on pulmonary function tests. On the flow volume loops, you can detect stenosis of central airways. And if there's a abnormality in ventilation and perfusion, that should also be evaluated with bronchoscopy. This is a typical type of extent of obstruction of central airway that would be necessary to cause abnormality on the flow volume loop. This is a carcinoid tumor, but it can also have extrinsic obstruction of the windpipe, such as this, which would result in a very flat volume loop. Now, other pertinent findings that sometimes warrant bronchoscopic examination include a positive sputum cytology in a patient who has a chronic cough but no radiograph findings. Most patients with lung cancer should have staging of their tumor bronchoscopically. In cases where you suspect that there may have been injury to a major airway in patients with trauma, bronchoscopy is important as an early evaluation, and of course routine postoperative evaluation of patients undergo bronchoplastic operation. In terms of staging lung cancer, we'll go over this a little bit tomorrow. We're talking about lung cancer where proximity to the carina is an important element in the T status. You also can stage for fistulization into the esophagus, as seen here. And then the variety of therapeutic indications including management of retained secretions, extraction of foreign bodies, dilation or stenting of airway stenoses, laser therapy for hemolysis, drainage of abscesses, and so on. This is the typical sort of patient with retained secretions that would require therapeutic bronchoscopy. And this is a patient who has just completed laser therapy for squamous cell carcinoma of the trachea. Now, if I back up, I could also propose to you that that's an anastomosis following a bronchoplasty, but that would be lying. This is a patient who's ingested, or I should say aspirated marble into mainstem bronchus. Rather difficult to get out with most of the standard tools that we have available. So those are the indications. In terms of specific contraindications for bronchoscopy, patients who have severe hypoxemia on room air, that would be less than 50, or substantial cardiovascular instability. Of course, bleeding diathesis is not an absolute contraindication, but would be a contraindication to brushing or biopsy. Similar caution exists in patients with pulmonary hypertension, particularly if a patient requires transbronchial biopsy. The evidence for pulmonary hypertension would be a very strong contraindication to transbronchial biopsy. For bronchoscopy under sedation, poor cooperation on the part of the patient is a strong contraindication, and you should give serious consideration to the general anesthetic in those patients. And of course, if you're going to do a rigid bronchoscopy, the patient's got to be able to hyperextend the neck to permit entry of the scope into the airway. Now, most patients should have flexible bronchoscopy because it's less stressful for the patient. The cost is probably less because most of the time when you're doing rigid bronchoscopy, it requires a general anesthetic, and that's not necessary for the vast majority of flexible bronchoscopy. You get a much better view of the periphery, of course. The downside is that the biopsies are smaller, and in patients who are experiencing complications or in whom complications develop, it's much more difficult to control. I'm thinking particularly here of loss of airway, and patency, and massive hemoptysis. This is the relative degree of view that you get in the airways. The lobar and segmental bronchi origins are visible the rigid scope of the subsegmental bronchi are generally all visible with the flexible scope, making it much more useful for most of the standard diagnostic work that we do. The rigid scope is valuable for certain specific indications. One is maintenance of the airway. You can get larger biopsies with this, so if you fail to achieve diagnosis of an endobronchial mass with flexible bronchoscopy, it's sometimes useful to perform rigid bronchoscopy. And of course there are special applications such as dilation of airway stenoses, stent placement, and so on that should most often be done with a rigid bronchoscope. The downside is that it's technically more difficult, and many people in this day and age don't possess sufficient skill to do a good job with a rigid bronchoscope. Certainly the vast majority of the pulmonologists don't have this skill any longer. It's much more costly for reasons that we've already spoken about. And for standard work, you get a much poorer view of the periphery, so it's not useful in the standard diagnostic evaluation patients. Now, patients who are undergoing bronchoscopy should be monitored fairly closely. Standard these days is to have an EKG tracing, automated blood pressure monitoring, and pulse oximetry. As well, in the room, you should have some sort of a crash cart if it's being done outside of a hospital setting. And the standard procedures that we would have available for doing bronchoscopy include the ability to do washings, brushings, biopsy of visible lesions, and transbronchial biopsy. As well, it's not necessary to have C-arm available to do transbronchial biopsy unless you're going at some specific lesion, but for 5 lobar infiltrates in which a random sample of the lung is necessary, the C-arm doesn't provide any additional benefit. Bronchoalveolar lavage is a straightforward procedure that should be able to be done under routine circumstances, and you can also get so-called Wang-style needles for doing transbronchial needle aspirates. This is just a standard bronchoscope and the types of biopsy and grasping forceps that should be available in most settings. And this just indicates a selective transbronchial biopsy of a right upper lobar lesion. As well, you can do aspiration of transbronchial aspiration of lymph nodes, staging for diagnosis of mediastinal and hilar adenopathy. This is the typical instrumentation that is routinely necessary for doing rigid bronchoscopy. Both the bronchoscope itself, a telescope generally used with a video camera set up these days, and video biopsy forceps, as well as dilators, swabs, and so on. Now, the technique for doing rigid bronchoscopy, just to briefly review, is to have the patient anesthetized and have the ability to hyperextend the neck when necessary. Be careful to protect the incisors of the maxilla with your operating hand so there's no injury to the dentition. Insert the scope so that the long portion of the tip is facing anteriorly. Identify the epiglottis and then lift that up and go down to the cords where further forward displacement of the scope is necessary to go between the cords. And then visualization of the left mainstem bronchus and lobar bronchi is performed by turning the patient's head to the right, and similarly the visualization of the right tracheobronchial tree is performed by turning the patient's head to the left like this. There are also different angled lenses and so on that can get around corners if necessary. In terms of complications of bronchoscopy, airway obstruction due to oversedation, secretions, and so on is probably the most common, as well as is hypoxia. And you'll find that most patients who are undergoing monitoring of oxygen saturation will experience some periods of relative hypoxia, and oxygen, supplemental oxygen, should be available at all times when you're doing bronchoscopy. Laryngospasm is fortunately uncommon and generally resolves without any specific treatment. Pneumothorax will occur in 10 to 20% of patients who have aggressive transbronchial biopsy, regardless of whether the C-arm is used. Atrial arrhythmias are relatively common but require no treatment. Hypertension is not often a complication, certainly rarely requires treatment in these patients. Now, if there are no questions about bronchoscopy, I'd like to move on to esophagoscopy briefly. Once again, in terms of indications for esophagoscopy, for evaluation of clinical symptoms, dysphagia or odynophagia should always be evaluated endoscopically, probably as the first step in evaluation as opposed to barium swallow. Persistent vomiting occasionally, persistent reflux symptoms, the patient fails to respond to a standard course of anti-reflux therapy using a minimum of H2 receptor blockers, it would be appropriate to perform endoscopy on them. And then occasionally upper abdominal or chest pain that's not responsive to standard therapy. And all these indications are straight out of the American Society of Gastroenterologists manual. Investigation of pertinent findings, including radiographic findings, these would be mass-like abnormalities on barium swallow. Initial evaluation, caustic injury to determine whether or not injury is present and the extent of injury. In some cases of thoracic trauma, particularly penetrating trauma, where you're trying to rule out an esophageal perforation. Most cases of GI bleeding as a preoperative evaluation for anyone undergoing esophageal or gastric surgery, and of course for surveillance of patients with Barrett's esophagus. We'll talk a little bit more about the appropriate interval of surveillance in a few minutes. This is a typical patient with grade 3 esophagitis. You can see linear ulcerations here with some fibrosis at the base, and one of the more common indications for doing upper GI endoscopy. This is a patient with a fibrous stricture at the at the squamocolumnar junction due to acid reflux. And this is a patient with early stage Barrett's esophagus. You can see tongues of the columnar epithelium extending up here beyond the squamocolumnar junction. And this is a patient with Barrett's adenocarcinoma, relatively early stage non-circumferential arising in a typical Barrett's mucosa here. It's also useful for grading of esophageal varices, and also when we talk about therapy for sclerosis esophageal varices. Now, in terms of other diagnostic evaluation, one can also perform endoscopic ultrasonography. This is something that's not available still in the majority of hospitals, mostly because of a cost factor. This is the standard endoscopic ultrasound endoscope that's currently available. It has a ultrasound emitter and sensor at the tip, and it has a side viewing optics. Some of the newer scopes also have a biopsy channel, working channel coming out the side. And this tip is covered with a balloon that's filled with deaerated water. This is a cross-sectional picture of the esophagus now. B refers to the balloon. This is scope itself, and all this black area in here is balloon. And then the esophagus itself is divided into 5 alternating hyper and hypoechoic layers corresponding to the mucosa, submucosa, muscularis propria, and so on, as labeled down here. And with this, one can determine esophageal wall abnormalities. It's particularly useful for looking at degree of inflammation for evaluating Barrett's esophagus. It is most commonly used for staging esophageal cancers, and one can get a determination of the extent of penetration of an esophageal cancer into the wall of the esophagus with this, which of course determines the T status. You can see here a tumor labeled T, which is infiltrating into but not through the muscularis propria. It's also used for looking at regional lymph nodes. You can see here on this blown up view the aorta, the azygos vein here, the balloon rather eccentrically blown up here because of irregularities in the lumen of the esophagus. And this is the tumor here. You can see a couple of lymph nodes illustrated here, which are both pathologic, not on the basis of size, but on the basis of their contour and their internal echo pattern. Size, of course, is not a very good criterion in patients with esophageal cancer for determining malignancy or benign situation in those nodes. So what we look at is the contour. If the contour is ill-defined and relatively regular, that suggests the node is benign. If the contour is very sharply demarcated, it suggests that the node is likely to be malignant. The other thing is that the internal architecture of the node is irregular. That's likely to be a malignant lymph node. So those three things are looked at with sound endoscopy: size, contour, and internal architecture. And the general finding has been that one can diagnose T-stage with about 90% accuracy, which is a lot better than the 60 or so percent accuracy with CT scanning combined with endoscopy and barium swallow. One can also look at the regional lymph nodes and diagnose those with an 85 to 90% accuracy, which is also substantially better than with any of the other tests that we have currently available. The problem with ultrasound endoscopy is that about a third to half of patients with esophageal cancer their tumors will not permit passage of that scope into, and certainly not through, the tumor, and so they can't be completely staged using this technique. What's on the horizon and is available very soon are these probes that will fit down the working channel, the larger working channels of standard scopes, and permit staging evaluation of most patients now with esophageal cancer. The final question is whether this additional accuracy in staging is going to affect treatment or outcome of management of these patients, and that is an unresolved question that is quite an important one because it's an expensive and somewhat time-consuming technology. In terms of therapeutic esophagoscopy, of course, foreign body removal, dilation of patients with malignant or benign strictures, as I mentioned before, sclerotherapy of esophageal varices, insertion of stents for either benign or malignant strictures, and of course, laser use or brachytherapy are all important therapeutic indications for esophageal endoscopy. Now, the contraindications include cardiovascular instability of a severe nature, bleeding, and poor cooperation, as mentioned before. For patients who are going to have rigid esophagoscopy, the inability of the patient to extend his or her neck is a very strong contraindication. One thing that's a little controversial is whether or not endoscopy should be performed for patients who have suspected esophageal perforation. This goes for both the Boerhaave's barogenic trauma as well as for penetrating trauma. In the gastroenterology community, this is a relatively strong contraindication to endoscopy. I think in the surgical community, this is a reasonably good indication for endoscopy. The accuracy of endoscopy in assessing esophageal penetrating injury about 90 to 95%. It's equivalent to that of contrast esophagram. And of course, in many patients who have suffered acute trauma, contrast studies can't be performed because of their mental status or other associated injuries, and endoscopy is an important element in the evaluation of those patients. Now, we use the flexible scope most commonly for the same types of reasons that we use flexible bronchoscopy. The downside is that it requires a lot more air insufflation, which is a major complication, if you will, that these patients complain about after endoscopy. With the larger biopsy channels that we have these days, the small biopsy is not really a complaint. You can have the standard biopsy cup forceps like this. I more often use the bayoneted forceps like this because you can get a better purchase on the tissue. And then, of course, there are a lot of needles that are available for doing both injection and for doing aspiration. And sometimes cytology is a useful assessment assessment to make when you have no clear-cut abnormalities of the overlying mucosa. The rigid scope is used even more rarely than the rigid bronchoscope. The indications are to do biopsies when your standard flexible esophagoscopic biopsies have failed to achieve a diagnosis. Generally speaking, pediatric patients need to be anesthetized for this procedure, and the rigid scope is important to use in the younger pediatric population. And almost always we would do foreign body extraction using a rigid as opposed to a flexible telescope. The same caveats apply when talking about rigid esophagoscopy as compared to rigid bronchoscopy. It's much more difficult. Technically, the risk of perforation is substantially higher. The cost is higher, and you get surprisingly poor visualization unless you use a high-quality telescope down the rigid scope accompanied by a video camera system. These are the typical sizes of rigid scopes that are available for use. The manufacturers all have slight variations, but you can see the wide variety of things available. And for dilating very difficult strictures, and sometimes it's useful to start with these longer but quite narrow scopes and work up to the large scopes. The techniques include adequate monitoring. The same monitoring is used for esophagoscopy as bronchoscopy, pulse oximetry, heart tracing, and automated blood pressure monitoring. Generally speaking, the depth of sedation doesn't have to be quite as great for esophagoscopy as it does for bronchoscopy. In fact, many people do esophagoscopy without any sedation whatsoever, just using a local anesthetic if they're doing a really quick study. A standard crash cart needs to be available in whatever unit the procedure is being performed. This is oftentimes a so-called office-based procedure. The patient is generally placed in a decubitus position with the left side down to decrease the secretions pooling at the back of the throat, and also to get the secretions, the gastric secretions, away from the pylora so a more complete examination can be performed. Once again, standard biopsy forceps should be available, and brushes should be available for doing diagnostic work during all of your endoscopy. In addition to standard biopsies and so on, dilation can be performed over flexible guide wires, such as illustrated here, using the olives, for those of you that like the old-fashioned way, or using the tapered Savary-style dilators, more modern way. Also, you can do balloon dilations using a through-the-scope balloon, such as illustrated here. And the complications are similar to those for bronchoscopy. Aspiration is a serious consideration and is much more common in patients who are more heavily sedated. So I think titration of the level of sedation is quite important in these patients. Bleeding is very uncommon. Hypoxia is relatively common, and standby supplemental oxygen should always be available in the room. Laryngospasm is not generally a problem, nor is arrhythmia. The rate of perforation is exceedingly small in patients who are having diagnostic flexible esophagoscopy. It's in the range of 0.01 to 0.02%. Of course, in patients who are undergoing dilation of peptic strictures or dilation for achalasia, the rate is substantially higher, in the range of 1 to 2%. There are no questions about esophagoscopy. Yes?
In what patients do you insist that a GI with barium be performed prior to endoscopy?
I don't generally insist that anybody have it done. It used to be said that patients in whom you're concerned about a Zenker's diverticulum, for example, would be a common indication to require a contrast study first. And that was mainly because the scopes that they had available at the time were of relatively poor quality, and a lot of these patients were having rigid endoscopy as opposed to flexible endoscopy, and the risk of perforation the real risk of perforation was quite high in those patients. These days, with the quality of scopes that we have, and with intubation of the esophagus under direct vision as opposed to blind intubation of the esophagus as we used to do, the risk of perforation of a Zenker's diverticulum would be exceedingly small. So I can't think of a situation where I would require a barium swallow to be done. Obviously, if one has been done, it would be prudent to have it available for review before you're doing your endoscopy. It would be a mistake to not review it. But as I said, I think at the beginning, it's endoscopy more and more is becoming the standard initial evaluation as opposed to contrast esophagram. Other questions? Yes?
Bronchial adenoma is still a contraindication of biopsy?
No. In a pulmonologist's hands, maybe. In a surgeon's hands, it shouldn't be. You should be able to control bleeding adequately with pressure, topical application of epinephrine. Other questions? I'm sorry, let's move on to stenography now. Now, the indications for doing mediastinoscopy include the diagnosis of mediastinal masses, and you'd be surprised at the number of referrals you get for doing cervical mediastinoscopy for masses that are nowhere near the typical plane for standard cervical mediastinoscopy. The medical community, I don't think, is very well educated as to the techniques for mediastinoscopy and the indications. So this is an area we have to exert some caution and probably do some teaching among your medical colleagues. It's quite useful for evaluating mediastinal adenopathy. It's important for staging intrathoracic cancers, particularly lung cancer, and for assessing the etiology of recurrent nerve damage or other local manifestations of what is presumed intramediastinal malignancy. The specific contraindications are similar to those for endoscopy, bleeding, diathesis, or severe instability. What used to be considered relatively strong contraindications are no longer, by and large. Prior mediastinoscopy, it's been shown now, is not doesn't hamper doing a standard cervical mediastinoscopy, and similarly, I've many times repeated a peristernal mediastinotomy after one has been done previously. Mediastinal irradiation, where it does lead to a slightly higher incidence of complications, is not a contraindication, nor is superior vena cava syndrome. In fact, SVC syndrome is a relatively strong contraindication to do a diagnostic mediastinoscopy in the absence of other means of achieving a tissue diagnosis. Now, there are two standard ways of doing mediastinoscopy. The most common, of course, is the Carlin's cervical mediastinoscopy, and this is done primarily to stage right lung cancers or left lower lobe cancers. Is not quite as good in the absence of radiographic findings of mediastinal adenopathy for evaluating left upper lobe cancers, because those most often metastasize to the station 5 and 6 levels, which are not accessible with routine cervical mediastinoscopy. It's good for looking at mediastinal masses that are in the middle mediastinum. Generally speaking, with standard cervical mediastinoscopy, the anterior mediastinum and the posterior mediastinum cannot be accessed, and it's quite good looking at paratracheal adenopathy. In cases where there is an anterior mediastinal mass, or where you have adenopathy in the AP window or pre-aortic region, then it's more appropriate to consider peristernal mediastinotomy. And that's also best for staging left upper lobe cancers, the so-called Chamberlain procedure. This is an illustration of the typical nodes that would be accessible through a cervical mediastinoscopy. Stages 1, 2, 3, generally speaking 4R. You'll oftentimes, but not always, be able to access station 4L. You can get at station 10R much of the time. Station 7 is accessible in the anterior region, but the posterior subcarinal lymph nodes are generally not accessible with cervical mediastinopscopy. And the major problem is that you're not going to have very good access to stations 5 and 6. I'm sorry, they're over here, 5 and 6, which are commonly involved with left upper lobe cancers. By the way, if it's not already apparent, it's very important for purposes of the boards to have the lymph node stations committed to memory. There's a lot of questions about that. This is an illustration of typical cervical mediastinoscopy, an incision a finger breadth or two above the sternal notch. It's a mistake to make this right at the sternal notch as you would for a transcervical thymectomy. You really need access to the pretracheal plane, which is available up a little higher than the standard incision, and then dissection down between the strap muscles, incision in the pretracheal plane, blunt dissection of that digitally, and then insertion of the scope. All of our standard mediastinoscopies are now done with a video mediastinoscope, and the reason for that is it helps the nurse figure out what you're doing down there, and it's also, from my perspective, great for training residents and fellows. I suspect that most of you don't have the latter consideration, but it is a very nice view, although the bleeding is a little more alarming when you see it on the camera, all magnified. So these are the typical locations of lymph nodes that you can access with a cervical mediastinoscopy. Where you can't get then is to the pre-aortic nodes and AP window nodes as illustrated here, and of course none of the supraclavicular nodes are accessible with that. And these would be the node regions best staged with anterior mediastinotomy. The anterior mediastinotomy can be performed either in the left or the right. The incision I make vertically, some people make it horizontally like this. It's cosmetically more appealing horizontally, but vertically you can move up or down in interspace if you find that the pathology is in a different location than your initial assessment on the basis of radiographs. Yeah, in larger patients you can go between the ribs, and in smaller patients I typically will remove one of the costal cartilages, preserving the perichondrium so that can grow back. And then the plane is bluntly dissected between the parietal pleura and the mediastinum. This is showing it sort of oddly from the right side, and most often it would be done from the left, and from the left side the scope drops down to about the level of the descending aorta like this. You have very good access to AP window nodes, and also can get access to anterior mediastinal masses, such as illustrated here. And then in more extreme situations, you can do this sort of gynecologic bimanual palpation of the mediastinum. The complications are very infrequent. This is done typically now as an outpatient procedure. We rarely will admit patients for overnight postoperatively, except if they're very elderly or fail to recover completely from their anesthetic. I would say in 10 years I've had one patient who's had a bleeding problem that required opening the chest up, and I made a mistake because I could have controlled it with lips. Recurrent nerve injury is a rare problem. Phrenic nerve injury is fortunately rare if you have sufficient blunt dissection before your biopsies. Pneumothorax should not be a problem in most patients. Will commonly enter the visceral pleural space, and all the anesthesiologist has to do is hyperexpand the lungs as you're closing up. Drainage is rarely necessary. Esophageal perforation is not a common problem. Assuming that you have a relatively normal anatomy in the mediastinum, I've had some patients who've had the esophagus rotated up lateral to or anterior almost to the trachea by virtue of aberrant mediastinal vessels, and that led to a perforation in one case that I reviewed. Fortunately, I didn't perform. Infection is a rare complication of this. So all of these complications should be quite rare, and mortality should be zero eventually. So questions about mediastinoscopy. I'm not going to address the indications in terms of lung cancer itself. I think we'll talk about that tomorrow when we talk about lung tumors. Yes?
Have you ever done the extended
mediastinoscopy?
No, I think that the only people that are doing it are the two people that have published it, to tell you the truth. Even the people I know who have trained with Ginsburg don't do that technique. It's, I don't know how to do it, and my opinion of it is that it's kind of dangerous. Unless you're very experienced, I don't feel safe doing it myself. It's certainly not a standard technique. The questions? Yeah.
What do they do?
Extended mediastinoscopy is there's two techniques that are described. In one technique, you pass the mediastinoscope outside of the mediastinum, anterior to the aorta, between the innominate artery and the carotid or subclavian, depending on where you need to get to. So you can get to those station 6 lymph nodes. And the other is that you pass the scope beneath the aortic arch. And it's, I think you have to have a mucho cojones to perform that personally. So first of all, we're going to talk about gastroesophageal reflux. And what we need to understand is that reflux is a very common event in so-called normal individuals. And you can see the relative frequencies here. What we're going to be talking about is pathologic reflux. And we call it pathologic when it is a much higher frequency than in the normal individual, when the symptoms are much more severe than in the normal individual, or when complications of reflux, such as bleeding or peptic stricture, develop. Now, when any one of these is present, then we're talking about gastroesophageal reflux disease, or GERD. Just to review a little bit the physiology of the esophagus and stomach so that you understand what the abnormalities are that develop in gastroesophageal reflux problems. The anatomy of the stomach esophagus is important to understand. As you know, the esophagus is made up of longitudinal, outer longitudinal and inner circular muscle layers, all smooth muscle in the distal esophagus. And these layers form a confluence into the layers of the gastric muscle. If you look at them more closely, the inner circular layer of the esophagus interdigitates with so-called sling fibers that extend from the lesser curvature of the stomach to the angle of His. And so in a relaxed situation, when these sling and clasp fibers are not contracted, you have a fairly obtuse angle of His, whereas with normal tone, as seen here, you have a slightly smaller diameter of the esophagogastric junction and a much more acute angle of His. This is felt to be one of the most prominent components of the esophagogastric anti-reflux mechanism, which is a much more inclusive term than the lower esophageal sphincter that I'll be referring to for the rest of the hour here. The other portion of the other most common portion of this anti-reflux mechanism is the length of intra-abdominal esophagus, the length of esophagus that's exposed to intra-abdominal pressure as opposed to intra-thoracic pressure. Now, this asymmetry that develops with the interdigitation of the clasp fibers and the sling fibers can be seen manometrically if you measure pressures in the lower esophageal sphincter as seen here. So you have much higher pressures anteriorly than posteriorly and much higher pressures on the left side than the right side, the left side being where the angle of His is. Now, these are tracings that illustrate the most common reasons for gastroesophageal reflux events. The first one illustrates 3 different levels within the esophagus. One is esophageal pH, The other is lower esophageal sphincter pressure. These are British slides. We're talking about the oesophagus as opposed to the esophagus, and the other is intragastric pressure. And in one, we have a normal intragastric pressure, a normal esophageal pressure here, and normal esophageal pH. And what happens here is there is transient, spontaneous relaxation of the lower esophageal sphincter, leading to a reflux episode in which the intraesophageal pH drops down below 4, all associated with a persistently normal intragastric pressure. This happens frequently at night, and it was one of the common causes for sporadic nocturnal reflux that is usually not associated with esophagitis or so-called gastroesophageal reflux disease. Another abnormality would be a relatively low resting lower esophageal sphincter pressure, a normal intragastric pressure, but a spontaneous rise in intragastric / intra-abdominal pressure that is able to overcome the resting pressure in the lower esophageal sphincter, leading to a transient reflux episode, as illustrated here. And this could happen in patients who are coughing, vomiting, anything of that sort. However, the most common thing is that we have a patient with normal intragastric pressure and a low lower esophageal sphincter pressure. And these patients will have very frequent episodes of gastroesophageal acid reflux. So we find that lower esophageal sphincter dysfunction occurs with increased intragastric pressure or due to damage of the esophageal muscles due to such things as scleroderma or collagen vascular diseases, certain types of trauma. The most common, unfortunately, is reflux injury, and reflux injury setting up more muscle damage, causing decreased effectiveness of the sphincter mechanism and a vicious cycle of damage and increased reflux. There are a lot of other reasons why patients could have lower esophageal sphincter dysfunction. Patients who take hormones have decreased lower esophageal sphincter pressure, and increased levels of hormones during pregnancy, for example, leads to a high incidence of gastroesophageal reflux in women. Part of that is also because of increased abdominal pressure as well. Other increased levels of hormones will lead to drops in lower esophageal sphincter pressure. All of these drugs will decrease LES pressure. Certain foods as well, and those many of you will probably notice heartburn after drinking coffee or eating chocolate. There is a very well described decrease in lower esophageal sphincter pressure associated with exercise. It's been best documented in long-distance runners. But the most common cause for LES dysfunction is poorly understood and is associated with a low resting amplitude in the lower esophageal sphincter. Now, other factors can be delayed gastric emptying or gastric outlet obstruction, as in patients with peptic ulcer disease or gastroparesis. Poor esophageal clearance is a relatively common element in patients with long-standing gastroesophageal reflux disease. That smooth muscle damage that results from chronic reflux will decrease peristaltic tone and effectiveness in patients with GERD. And in certain individuals, the type of material reflux, particularly gastric and pancreatic enzymes, are important in the degree of damage, and also some tissues. In some individuals, the tissues are much more susceptible to this type of damage than in others. And these are perhaps the most poorly understood elements of gastroesophageal reflux disease. Would you change the carousel, please? We'll talk a little bit about diagnosis and then go on to medical and surgical therapy. The diagnosis is most often ascertained by simple clinical symptoms, the most common, of course, being heartburn. And in addition to heartburn, the common clinical symptoms include regurgitation, pain, and pain can be due to esophagitis, or it can be due to related to odynophagia, due to relative obstruction. Dysphagia as well can be due to either relative obstruction from, for example, a peptic stricture, or it can be due to relative poor peristaltic activity of muscles that have been damaged by chronic reflux problems. Oropharyngeal symptoms are quite common in patients with gastroesophageal reflux disease. They include things like water brash, chronically irritated throat, and so on. Pulmonary symptoms in adults are relatively common as well. Chronic cough is due in about 20 or 30% of patients to chronic reflux problems. The cough can be a reflex mechanism just due to acid within the esophagus, not necessarily affecting the vocal cords or posterior oropharynx. Or it could be due to local irritation or aspiration. There also is a bronchoconstrictive reflex that occurs when there's acid in the esophagus, or bronchoconstriction can be due to actual aspiration of micro amounts of acid. And in fact, about 20% of people with intrinsic asthma have gastroesophageal reflux as the primary underlying cause of their asthma. The problem with pulmonary symptoms and oropharyngeal symptoms is that they respond very poorly to conservative management, even with high-dose acid suppression. And so these patients more often qualify for surgical therapy than do patients with more standard types of symptoms limited primarily to the esophagus. Now, in terms of diagnosing patients who have reflux problems, the vast majority of people, it's clear that it's reflux on the basis of a simple history and physical examination. In those who have more severe symptoms, patients who fail to respond to simple, straightforward medical therapy, or those who have complications suspected as being due to gastroesophageal reflux disease, then more intensive investigation is warranted. Barium swallow is good primarily for assessing the anatomy of the esophagus and stomach. It's not very good for looking at physiology. You can have false positives and false negative reflux studies in at least 25 to 30% of patients. Endoscopy is quite useful in patients who have severe reflux problems, both to document esophagitis, to confirm diagnosis, and to rule out the existence of a more important problem, such as Barrett's esophagus. Of course, if you see Barrett's esophagus, you should always do extensive biopsies to ascertain the degree, if any, of dysplasia that's present. And in any patient with swallowing difficulties or esophageal symptoms that might possibly be related to esophageal cancer, to rule out the existence of malignancy. I think of manometry as being very useful in patients with reflux problems if one is considering surgery on these patients. I do it as a routine preoperative test, and the reason that I do it is because I probably see more complicated reflux than is seen in the community hospital. And it's important for me to determine the appropriate type of operation based partially on manometric findings. If you have patients with very severely compromised function of the esophageal body, I think it's important to do a lower pressure wrap in those patients than in those who have very normal function of the body. But other than that, you can make a diagnosis, you can confirm a diagnosis by dysfunction of the LES, but it doesn't really make a diagnosis of gastroesophageal reflux disease. In my opinion, it's still very important to consider pH monitoring of the esophagus in patients who have severe GERD. The reason for that is that patients who have very typical symptoms of reflux but fail to respond to standard medical therapy, about a quarter of the time will not have documentable reflux, either endoscopically or on pH monitoring, and that permits you to then pursue some other diagnosis. In addition, patients who have very severe symptoms of reflux, almost half of the time, will not have esophagitis on endoscopy, and you need to substantiate the diagnosis then with some other means. pH monitoring is the gold standard of the diagnosis of reflux in those types of patients. It's also very useful for patients with atypical symptoms, pulmonary symptoms particularly associated with asthma, chronic cough, and so on. Some patients will have manifestations of GERD but not have typical symptoms. For example, a peptic stricture will occasionally develop in a patient who gives no history whatsoever of reflux, and then pH monitoring would be important in those patients to rule out to confirm the tentative diagnosis of reflux. The advantages of the pH monitoring are, number one, that it's quantitative, so you can measure, you can actually provide a score for the degree of reflux they have, but you can also correlate individual episodes of reflux with individual symptoms or events that the patient experiences. What they do is keep a diary, and then you correlate the findings on the tracing with the events in the diary, and this is most important in patients who have respiratory symptoms or chronic cough and so on. There are two basic patterns of reflux that we see in patients. One is a pattern of frequent or infrequent brief episodes of reflux, as illustrated here. And these can occur during the daytime or at nighttime. They're more common to occur during the daytime. They're quite profound drops in esophageal pH, but very rapid recovery in a period of minutes or seconds even in some cases. And what this type of pattern will lead to is sometimes an abnormal weighted overall Demeester type score, but most of the time you won't find an abnormal score in these patients. And these patients typically are chronic nervous air swallowers who have a lot of belching, and every time they belch, they'll have a very transient episode of acid reflux, and it may not be associated with heartburn much of the time. In fact, they'll rarely report heartburn during these episodes. The more problematic refluxer is one who has persistent drop in pH in the distal esophagus over a period of 5-10 minutes or an hour or two. And this is more severe during the nighttime than it is during the daytime. There seems to be more damage that occurs at night than during the daytime. So this is a combination of poor lower esophageal sphincter function as well as poor distal esophageal clearance of acid. So you see here a patient with a normal esophageal pH above 4, and then about 1 a.m. it drops below 4 and really stays below 4 for a period of 2 hours. And this patient almost certainly will have severe esophagitis and symptoms of reflux. And the most severe of these types of patients are those who have prolonged episodes of esophageal pH exposure less than 4, both during the daytime and night, and so combined upright and supine refluxers. Now, most patients, 90% plus, who have gastroesophageal reflux disease will respond to non-surgical therapy. The standard measures for non-surgical therapy are immediate relief of symptoms using antacids and change in patients' habits or lifestyle, if you will. And that comprises of a variety of steps. One is to elevate the head of the bed while the patient is sleeping so that gravity maintains the gastric acid within the stomach and not in the esophagus. It also helps in clearance of esophageal acid. And elevation of the head of the bed can be done with a foam wedge or with pillows, with blankets folded and put under the mattress so the whole torso is elevated. The ideal way from my perspective is to have the whole entire bed elevated by putting wood blocks under the legs at the head of the bed. And it has to be elevated about 6 to 8 inches. You should caution the patients not to try to use pillows to do this, because all that will do is to flex the neck forward, and usually in the nighttime they'll roll off of the pillows and experience reflux events. Decreasing dietary fat, avoiding certain foods that are associated with reflux problems, maintaining an upright posture for several hours after eating and not eating bedtime snacks, and restriction of smoking are all the most important things that people mention for limiting symptoms in a relatively conservative fashion. One thing that people also mention is weight loss as being very important in limiting reflux symptoms and avoidance of tight or restricted clothing. In terms of pharmacologic therapy, antacids are good for immediate relief symptoms. If you compare antacids to placebos in a controlled double-blinded fashion, in patients who have esophagitis, the antacids are no better than placebo in healing esophagitis. So it's good for symptomatic relief, but not for control of tissue damage caused by the reflux. So generally speaking, if a patient comes to the physician's office for management of reflux problems, it's useful to put them on some H2 receptor blockers if they have mild or moderate symptoms, or acid suppression therapy with a omeprazole or similar drug if they have moderate to severe symptoms. The H2 receptor blockers, by and large, are all equally effective, so you judge the choice based on the frequency of dosage that's necessary and cost. And of course, the cimetidine now that's available over the counter is considerably cheaper than its predecessor, and I think that's true of most of the H2 receptor blockers now that are available over the counter. The omeprazole and lansoprazole that are the sodium, potassium, the proton pump inhibitors are both quite expensive, so I don't use them as first-line therapy unless the patients have relatively severe symptoms. The cost is in excess of $100 a month right now. There is a lot of concern initially about the use of these for an extended period of time, usually in excess of 6 to 8 weeks. That's no longer of much concern, and many people have followed patients on this medication for a year, 2 or 3, without adverse effects. Now, interestingly, prokinetic agents such as bethanechol and metoclopramide have been used for many years in an attempt to improve esophageal peristaltic activity, increase the tone of the lower esophageal sphincter, and improve gastric emptying. Unfortunately, if you compare these prokinetic agents to placebo, they have no demonstrated benefit. Now, the newest prokinetic agent, cisapride, does have substantial benefit in patients who have gastroesophageal reflux disease. If you compare cisapride to a standard dose of H2 receptor blocker, they are equivalent in controlling symptoms of reflux and in healing esophagitis. And the combination of the two is better than either alone in managing gastroesophageal reflux disease. Sometimes a cytoprotective agent is also useful in these patients, particularly for initial therapy of gastritis and associated esophagitis, and sucralfate is useful for that. Now, these are recent studies that came out. This one, I think, is from Italy, pairing the important combinations of medical therapies for gastroesophageal reflux disease. Cisapride, the prokinetic agent, versus an H2 receptor blocker versus a proton pump inhibitor, and then combining prokinetic agent with H2 receptor blocker, or combining the prokinetic agent with the proton pump inhibitor. And what you can see is the most effective standard therapy for gastroesophageal reflux disease in these patients with fairly severe reflux is the proton pump inhibitor. There's a slight improvement if you add prokinetic agent to that. And this is why I reserve this for patients with fairly severe disease. It's also interesting to see the relative rate of relapse in these patients comparing the 6-month outcome to 12-month outcome. You're losing 5 to 10% of your effectiveness in all the groups across the board. It's also important to remember, and this is illustrated well by Speckler's study from a few years ago that was published in the New England Journal, the comparison between medical therapy and surgical therapy. I think our medical colleagues probably don't admit this to themselves sufficiently frequently, that surgical therapy is very good for gastroesophageal reflux disease. Fortunately, with the laparoscopic approaches that are available now, I think they're more enthusiastic about referring patients for operation. But if you look at medical therapy versus surgical therapy, patients with severe gastroesophageal reflux disease, they had similar grades of esophagitis at baseline, but substantial improvement at 2 years in the surgical group compared to the medical group. And this was also documented objectively on esophageal pH monitoring. There was greater improvement in the surgical group than in the medical group. And this is just another illustration of the activity index, or so-called symptom score, in these patients, showing that the level of symptoms decreased much greater in the surgery group than either the sporadic medical therapy or the continuous medical therapy group. Same study. So that brings us to surgical therapy of gastroesophageal reflux disease. Now, the indications for surgery are primarily complications of gastroesophageal reflux. And we'll talk individually about stricture, ulceration, a little later on about Barrett's esophagus. I'll just say right now and remind you that pulmonary symptoms are relatively unresponsive to medical therapy. And if a patient has relatively severe pulmonary symptoms that are proven associated with gastroesophageal reflux, they should be considered earlier than your typical patient for surgical intervention. I will talk about myotomy for motility disorders and the utility of fundoplication when we talk about utility problems, so we'll avoid that for right now. One of the primary indications, at least in my practice, is failure of medical therapy or patients who are intolerant of medical therapy. And a subgroup here is relatively young patients who have relatively severe symptoms of gastroesophageal reflux. If you have somebody in their 30s or 40s, for example, who are going to face another half-century of medical therapy of reflux, it would be appropriate to consider in those patients operation relatively early. Now, the principles of surgery for gastroesophageal reflux disease are to, number one, restore the intra-abdominal length of esophagus, and this should be at a minimum 4 or 5 centimeters of intra-abdominal length. As you know, many of the patients that we operate on for reflux have small type 1 hiatal hernias, and mobilization of the esophagus is an important element in order to restore this length, no matter what technique you use, open laparotomy, laparoscopic, or open thoracotomy, to do the fundoplication. Calibrate the hiatal orifice. What this means is to close the crura, approximate the crura of the esophageal hiatus to a normal caliber. The third is to alter the angle at the cardia, and almost all of the current fundoplication techniques provide a maximally acute angle of His. So this is a standard element of all the fundoplications. And then, of course, to remain flexible in your approach. I mentioned earlier about the need to tailor the operation to the specific underlying motility disorder of the patient and to the degree of reflux that the patients are experiencing. So one should have within their armamentarium the ability to do a total versus partial fundoplication and to do approaches both through the abdomen and through the chest.